Thank you for joining this edition of CME Briefcase entitled The Future of Psoriatic Arthritis Care, From Teams to Treatments. Dr. Joel Gelfand has been kind enough to share his thoughts and insights with us today. Dr. Gelfand is Professor of Dermatology and Epidemiology, Vice Chair of Clinical Research, Medical Director, Dermatology Clinical Studies Unit, Director, Psoriasis and Phototherapy Treatment Center, at the University of Pennsylvania Perelman School of Medicine in Philadelphia. Dr. Gelfand is a nationally and internationally recognized expert in psoriasis, clinical epidemiology, drug safety, and clinical trials. He's the author of over 200 scientific publications, editorials, reviews, and textbook chapters which appear in journals such as JAMA, British Medical Journal, European Heart Journal, Annals of Rheumatic Disease, JAMA Dermatology, the Journal of the American Academy of Dermatology, and the Journal of Infectious Disease. These are Dr. Gelfand's disclosures. Our learning objective for today's CME cast is to evaluate data for the optimal care of patients with psoriatic arthritis. Welcome, Dr. Gelfand.
Welcome to this briefcase, The Future of Psoriatic Arthritis Care, From Teams to Treatments. CME Outfitters is the accredited provider for this continuing education activity. CME Outfitters gratefully acknowledges an educational grant from Janssen Biotech, administered by Janssen Scientific Affairs, in support of the CME CE activity. I am Joel Gelfand. I'm a professor of dermatology and epidemiology at the University of Pennsylvania in Philadelphia. So today we'll start with a brief case about the future of psoriatic arthritis care, from teams to treatments. Our learning objective is to evaluate data for the optimal care of patients with psoriatic arthritis. And we'll do a case-based approach. Our patient's name is Rachel. She's a 36-year-old woman with a normal body mass index. She's had psoriasis since age 28. She's had psoriatic arthritis since age 32. Her psoriasis affects her scalp, her arms, her legs, her nails. Her joints include joint pain in her hands and her feet. Today she complains about joint pain and is distressed by the pain in her hand as she can no longer enjoy her hobby, which is knitting. Her prior treatment for psoriasis include failing to achieve clearance on topical steroids, phototherapy, methotrexate, adalimumab, and apremilast. She's had no specific treatments for her psoriatic arthritis in the past. She once was on cyclosporin previously, but that was stopped due to side effects. So she's been a fairly experienced patient in terms of different treatments. Her current medication is etanercept, so this is her second TNF inhibitor, which is taking 50 milligrams once a week for the past 2 months. And she presents today for a flare of both her psoriasis and her psoriatic arthritis. Her family and social history is remarkable for a maternal grandfather, I should say, with psoriasis, a sister with type 2 diabetes, and a father with inflammatory bowel disease. Her past medical history is a diagnosis of Crohn's disease, which has been in remission for the last few years and not requiring any treatment. Her blood pressure is normal at 120/81. So on examination, her physician's global assessment was 4. These range from 0 to 5, 5 being very thick, very scaly, very red, and inflamed plaques. So this is pretty, this would qualify as having overall severe disease based on the global assessment. Her body surface area is 6%, and she has very sensitive areas involved, the scalp in particular, the forehead, so visible areas, has small patches on her elbows and knees. She has pitting and onycholysis, or lifting off of her fingernails. She has oligoarticular arthritis affecting 6 joints on her left hand and diffuse swelling of her right third toe, which would be consistent with dactylitis. Her CRP protein is barely elevated at 1.5. How would you treat Rachel at this point in time? Let's talk a little bit more about psoriatic arthritis. This condition affects up to 1/3 of patients with psoriasis, and it's a major comorbidity of psoriatic disease. It can result in loss of function and permanent disability if treatment initiation is delayed. The manifestation of psoriatic arthritis can be challenging because there's multiple different domains that are affected. It can be peripheral arthritis. It can be dactylitis, affecting swelling of a digit. It can be enthesitis, which is inflammation where the tendon inserts into the joint, say the Achilles tendon, for example. Of course, psoriasis is part of psoriatic arthritis. Psoriatic nail disease, which some people think is a part of enthesitis, and axial or spinal disease. About 1/4 of people with psoriatic arthritis are positive for HLA-B27. It's usually not used for diagnostic purposes, but sometimes can be useful, especially if people have predominantly axial presentations. And of course, dermatologists are uniquely positioned to recognize the early signs of psoriatic arthritis and be able to be the first line healthcare practitioners to diagnose this disease and make sure patients get adequate and early treatment. This is a study looking at depression and anxiety in people with psoriatic arthritis. So traditionally, patients with psoriatic arthritis may have more limited, more mild skin disease, but then have the second burden of joint disease. And similar to people who just have bad skin disease, people with psoriatic arthritis have this added burden of mood disorders that tend to commingle with psoriatic arthritis, both depression and anxiety. There's a number of patient-reported outcome measures that one can consider when evaluating a patient with psoriasis or psoriatic arthritis. These have been developed to assess patient perspectives on various quality of life domains. Common ones are just visual analog scales, a 10 centimeter scale, 10 being the worst quality of life, 0 being perfect quality of life. There's a variety of ones that are very relevant for joint disease, the Health Assessment Questionnaire Disability Index, the EuroQual 5D, it's a more generic measure of quality of life, the 36-item health survey, which is often used for research, not really used in clinic. And then there are some instruments that can be used, the PSAD-12 questionnaire, which is available on the Grappa mobile phone app, or the routine assessment of the patient index data 3, the rapid 3 questionnaires that can be easily done. We don't do these in my practice, but certainly my rheumatologist who practices right next door to me does and finds it extremely useful for monitoring the patient's disease activity and seeing how well they're doing with management of their symptoms. So let's talk a little bit about how we define severe disease, both in the joints and in the skin. So for severe psoriatic arthritis, what we're looking for is signs of erosive disease, and that means you need to do films. And usually for erosive disease, we're looking at erosions in the small joints on the hands and the feet. And so you need to do plain films those areas to look for that. If you pick up signs of erosion on x-rays of people with arthritis, then they really need more aggressive management and probably management by rheumatologists. Because these are people who are most likely to go on to debilitating psoriatic arthritis and permanent joint damage. Elevated markers in the blood could be helpful. Elevated CRP or SED rate could be elevated and tend to be portend higher risk of disease progression in the patient with psoriatic arthritis to permanent joint damage. The CRP is normal, the SED rate is normal. That doesn't help us a whole lot because they often are normal in people with psoriatic arthritis. In our patient example here, her CRP basically was normal. Now, long-term damage that interferes with function, joint deformities, clearly a sign of psoriatic arthritis that's severe, something we're trying to avoid. Highly active disease that causes a major impairment in quality of life. Our patient, in this case, has an activity she wants to pursue, knitting, that she's not able to do functionally due to her symptoms. Active psoriatic arthritis involving many sites, many different joints, dactylitis, and enthesitis. These are the patients more likely to progress. Or those who have function-limiting psoriatic arthritis at only a few sites. So again, there's multiple different types of presentations of this disease. It could be oligoarthritis, just a few joints on the hands, but it could be highly symptomatic and cause disability. Or those who have rapidly progressive disease. In my clinical practice over the years, I find that some of my patients will be fine for many years, never have any signs of psoriatic arthritis, and then out of nowhere they develop a severe acute presentation of this disease. And so we have to be vigilant all along the course of their condition. Now, definitions of severe psoriasis include a PASI greater than 12, greater than or equal to 12, a biosurface area of 5 to 10% or more, significant involvement of areas that cause a lot of impairment in health-related quality of life, like the face, the hands and feet, the fingernails, intertriginous areas like underneath the breasts, the underarms, or the groin, or genital disease, or the scalp. Impairment in physical or mental functioning, which can warrant a designation of moderate severe psoriasis despite having very minimal skin involvement. And so really, we think of this sort of as holistically. We don't say, well, you have to have a biosurface area more than 10% to have severe psoriasis. You could have 3% biosurface area that affects your scalp, it doesn't respond to topical medications, and impairs a person's quality of life. And we would consider that to be severe disease, justifying treatment with systemic agents. Let's talk about some of our therapies that we use for psoriatic arthritis. So we have non-pharmacological therapies, which are important to be aware of. This includes physical therapy, occupational therapy, smoking cessation, weight loss, massage therapy, and exercise. And oftentimes our rheumatologists are best suited to prescribe these interventions. So again, it's more just pharmacologic, it's lifestyle and adjuvant therapies that really bring the most degree of relief. Symptomatic patients, highly symptomatic patients, episodic use of NSAIDs, local glucocorticoid injections are sometimes considered by a rheumatologist. Oral small molecules, there's a variety of that used: methotrexate, sulfasalazine, cyclosporin, leflunomide, and apremilast. Now, it's important to recognize that some of these therapies are not so good for the skin. So sulfasalazine or leflunomide don't really have much efficacy on skin psoriasis at all. And so someone who has significant burden of disease in their skin, you would probably want to shift towards things like methotrexate or apremilast, which are more effective for skin disease, and say sulfasalazine or leflunomide. Cyclosporin, on the other hand, is effective for the skin, but it's not really been proven to be a disease-modifying agent for psoriatic arthritis, and is really seldom used at this point in time as a dominating agent, given the concerns of kidney problems associated with cyclosporin. TNF inhibitors, we have a number of them approved for psoriatic arthritis: etanercept, infliximab, adalimumab, golimumab, and certolizumab. Certolizumab has some advantages in that it's a pegylated fragment. It doesn't seem to cross the placenta. Doesn't seem to cross into breast milk. And so for women who have childbearing potential, this is often a highlighted therapy because there's good data that suggests that there's no risk to the developing child or to an offspring who is breastfeeding. These drugs are also approved and useful for axial spondyloarthritis. Ustekinumab is approved for psoriatic arthritis. Its mainly benefit is for peripheral arthritis. It's not particularly effective for axial disease, and that's an important nuance to be aware of. Similarly, secukinumab and ixekizumab are both approved for psoriatic arthritis. They're also effective for axial presentations of disease. So the patient who says, they're usually a younger patient in their 30s or 40s, they have back pain that they wake up with, and after an hour or so, they get moving, they feel better. That's a case where it's likely a inflammatory arthritis and not a mechanical issue, like a disc issue. There are other biologics available: CTLA-4 betacept, approved for psoriatic arthritis, not very effective for skin disease, and therefore something you probably don't want to use as much in someone who has significant skin disease that requires treatment of both. JAK inhibitors, tofacitinib, is approved for psoriatic arthritis, very effective for that indication. It is not FDA approved for psoriasis, although there is phase 3 data that it is effective. The higher the dose, the more effective the drug is. So traditional dosing of psoriatic arthritis is 5 milligrams BID. To get a better effect in the skin, you're usually looking at a dose of around 10 milligrams twice a day for JAK inhibitors for tofacitinib. And then our 23 inhibitors, IL-23 inhibitors, guselkumab, risankizumab, tildrakizumab, these are all being evaluated actively for psoriatic arthritis. Will likely be achieving approvals for psoriatic arthritis in the near future. And they've been quite promising in their phase 2 and phase 3 trials. And ultimately the question will be will they be as effective as the TNF inhibitors or potentially IL-17 inhibitors on psoriatic arthritis? And that's will be determined as the work moves forward. Certainly, they are highly effective for the skin disease and have the added advantage of only being dosed every 8 to 12 weeks. They also don't have any effect on worsening of inflammatory bowel disease, so they have to be considered about for the IL-17 inhibitors. So these are recommendations that came out in 2018 from the ACR-MPF guidelines with their recommendations. They mentioned that agents with no efficacy in IBD should not be used in patients who have comorbid IBDs. So essentially, they're trying to shift us towards therapies like ustekinumab or TNF inhibitors. But it's important to recognize that often the dosing is going to be higher of TNF inhibitors for those indications for IBD than they are for just joint disease. Similarly, the dosing for skin disease may be higher than it is for joint disease when you're thinking about TNF inhibitors, because you need a higher dose to get a response in the skin compared to what you need to get a response in the joints. In people who have psoriatic arthritis and inflammatory bowel disease, it's recommended to switch to a TNF antibody over a TNF-soluble biologic like etanercept. That's mainly along the lines of the fact that the monoclonal antibodies are useful for IBD. In active PSA plus IBD, it's recommended to switch to a TNF monoclonal antibody over a IL-17. Again, we know 17s don't really help IBD, may aggravate it. The next recommendation is that in patients with active PSA and IBD, despite having oral systemic therapy, that you would consider an IL-12/23 inhibitor biologic over an IL-17. And so again, the idea here is favoring therapies that treat both diseases over just the one. And of course, smoking cessation is recommended for our patients as well. Why are drugs in development for psoriatic arthritis? I think the advances we've seen in skin disease, these very high PASI 90 results, are still not mirrored in the psoriatic arthritis population, where you're still talking about ACR 20 and 50 results. It's hard to get patients into deep remission the way we get them with their skin. So there's a need for more therapies out there. So we have a number of 23s in development: guselkumab, tildrakizumab, risankizumab, brodalumab, which is an IL-17 inhibitor, is under evaluation for psoriatic arthritis. It's currently approved for psoriasis. Bimekizumab, which blocks not just IL-17A, which is a target for the current IL-17s in the market, but also IL-17F. It has very high efficacy in the skin and is being evaluated for psoriatic arthritis. And then there are other JAK inhibitors that are more JAK1 specific that are under evaluation for psoriatic arthritis. Let's look at some real-world treatment patterns in people with biologics for psoriatic arthritis. And here what we see and what's important to recognize is that none of our therapies really solve this problem universally. And so therefore, it's important to have an algorithm and have many treatment options available to you. What you see here is that most patients, roughly 20% of patients who are put on a biologic for their psoriatic arthritis will stay on that same biologic over a 2-year period of time, demonstrating the need to have multiple therapeutic options available to you. Now, in this analysis, the most common treatment switch to when someone was changing biologics was adalimumab, one of the TNF inhibitors, followed by a whole series of other TNF inhibitors available, with ustekinumab being second after adalimumab as well. Secukinumab was a newer therapy at this point in time when this analysis was done. I suspect if we redid this analysis now, you would see that a patient who, say, is on a TNF inhibitor therapy for their joint disease, if they failed it or lost response, they may be getting switched to IL-17s, which seem to have very similar efficacy in the joints as the TNF inhibitors do. This also brings up the importance of multidisciplinary care. People with psoriatic disease, those with psoriasis and psoriatic arthritis, have a number of other comorbidities that one needs to be concerned about. We talked about anxiety and depression earlier on. We talked about the risk of severe advancing disease and those who may need joint replacements. Well, you want to make sure you have an orthopedic surgeon who's knowledgeable about this condition, and therefore you can work and coordinate care for those who need joint replacements. Cardiovascular risk prevention is important for these patients. Comorbid bowel diseases like Crohn's disease often affect our patients. And of course, those with psoriatic arthritis are prone to things like uveitis that needs to be managed and identified, often presenting with a red eye, painful eye, and potential blurriness of vision. And of course, the key here is early recognition of the disease and early institution of therapies with the goal of promoting joint damage and improving patient outcomes. So with that, I will close with our SMART goals today, which are to initiate treatment of psoriatic arthritis to control signs and symptoms, improve physical function, and prevent disability, improve health-related quality of life. Today, we try to demonstrate to you the variety of domains that are affected by people with psoriatic arthritis, the various joint presentations people have, and the whole therapeutic armamentarium we have available to us, and the need to be aware of all these therapies and have an algorithm for using them, because most patients will not be able to be on one treatment and have their problem well controlled for many years. On average, most patients will switch on to another therapy within a couple of years of starting it. I want to encourage you to claim ABIM MOC credit by following these recommendations here. And I want to also encourage you to use the MIPS program for improving outcomes in your practice. There's instructions on how to do that here. I also want to make sure you complete the survey at the end of the program so we get feedback from you about how we can improve these educational opportunities for you. We take that at Council very seriously, and we need it to improve the educational products we deliver to you. Finally, I want to thank you for joining me for this educational activity. I hope it will help you identify and treat psoriatic arthritis with greater confidence and greater success in the future.